Welcome to Ask Dr. Mingle, the Q&A series from Mingle Health answering your questions about quality programs and the transition to value-based care. I'm Dr. Dan Mingle. I'm a family physician, founder and CEO at Mingle Health. I'll be hosting this episode today, and we have with us Laura Dietzel. She's a Senior Clinical Informatics Analyst with Mingle, and she will help me with this episode about Medicare CQMs. Welcome, Laura.
Thank you. Good to be here.
Oh, quick reminder before we begin, you can always send us a question on LinkedIn, YouTube, or email us at hello@minglehealth.com. Please send your questions. If we raise any additional questions in your mind with this session, let us know. We can clarify in future sessions. So Laura and I are together to talk to you today about Medicare CQMs. Laura, why don't you kick things off?
Well, first of all, I thought it'd be really great if you started us with a primer of these new measures that CMS has introduced for the ACO clients. A great overview. You're always really good at very succinctly summarizing a lot of very complex information that comes out of those regulations for us. So maybe you could just walk us through how these measures are different than the registry measures.
Well, thanks, Laura. That's a great idea. Medicare wants ultimately to be in all digital quality reporting, and they want one quality standard to apply to all groups of patients, not one for Medicare and one for everyone else. Thus, they want to move ACOs to the all patients, all payer reporting to which MIPS submitters have been subject since the onset of MIPS in 2017. Medicare introduced the APM Performance Pathway in rulemaking for 2021 with plans to sunset the web interface and replace it with a set of 3 submitted measures submitted by eCQMs or by MIPS CQMs on all patients of all payers. The APP measure set also has 2 administrative claims measures calculated by Medicare on Medicare claims. Medicare has been subject to intense lobbying from ACOs to postpone the sunset of the web interface. In 2024 rulemaking, Medicare introduced Medicare CQMs. They included the implied refusal to postpone the expected sunset of the web interface. Medicare CQMs are intended to be temporary to allow ACOs more time to bridge the technology and process gap between first, the predominantly manual process of estimating quality and performance on a sampling of 248 Medicare patients for each of the 10 quality measures for the web interface. The more intense technical and methodological requirements, say that a few times real fast, to measure quality performance in all patients of all payers for all the measures of MIPS CQMs or eCQMs for the APM Performance Pathway.
Great summary, Dr. Mingle. Thank you. Maybe we could cover now what exactly are the Medicare CQMs?
Well, the specifications and methodology for Medicare CQMs are exactly the same as MIPS CQMs. Now, you can't do them as eCQMs. Medicare CQM measure specifications are only available for the submittable measures of the APP. You can't use them in MIPS or any other quality reporting program. The numerator and denominator specifications for each measure are identical to their MIPS CQM counterparts. You can use any method to collect and analyze data for MIPS CQMs and Medicare CQMs that you can use for eCQMs. But the reverse doesn't hold true. MIPS and Medicare CQMs have flexibility that you lose in eCQMs. Yeah, you can't use manual methods. You can't use non-certified data sources. It's really quite restrictive to do the eCQMs. Now, there's only one important way that Medicare CQMs differs from MIPS CQMs. Instead of all patients, all payers, as required by MIPS CQMs and eCQMs, it's only patients that are covered by Medicare Part B, and it's only Medicare Part B patients seen at least once in the performance year by a primary care provider in any of the 10 practices, any of the tax ID number practices participating in the ACO. For Medicare CQMs, the list of primary care providers comes from the extended list of specialties and credentials that sometimes function as primary care.
Maybe you could tell us a little bit how Medicare CQMs will help ACOs with their quality measure reporting.
Well, looking nationwide, about 12% of adults seeing a healthcare provider in any year are Medicare recipients. Because of specialty, scope of care, special needs, patients tend to focus on certain practices. So in reality, practices that are seeing Medicare patients on the average have about 30% of their patient population in Medicare. Specific practices can be higher or lower. The main point is that a significantly smaller number than the all-patient, all-payer population is Medicare in most practices. For most of the work we do for clients at Mingle Health, it doesn't matter much. If we're working with electronic data, which is our preferred standard, it doesn't really matter if we are analyzing 1,000 patients of all payers or 300 patients with Medicare Part B. It might take a few seconds longer to transfer the data and run the analytics, but it's nearly the same effort to us. But if you need to do some manual work to improve the accuracy of your reporting, Medicare CQMs is significantly easier because of the lower patient counts.
Can you use the Medicare CQMs and the MIPS CQMs in the quality submission for ACOs?
Yes, you can, Laura. Your submission, at least for 2024, can be any combination of MIPS CQMs, Medicare CQMs, and eCQMs. They can even be duplicative. You could submit all three measures all three ways. Medicare will give you credit for the best score found in your redundant submissions. Now, Laura, Medicare intends to provide practices with a list of patients. They'll provide the list quarterly, and it lists every patient that they've seen from Medicare's claims stash who might qualify for inclusion in Medicare CQMs. Are you able to use that list to generate the submission? Do you want to? What are the pros and cons of that list?
Yeah, the list has been a great resource for a couple of our clients. Again, the challenge for the Medicare CQMs is identifying all the correct payers so that we can do the filtering on our end. And that's been a challenge ACOs, of course, can have across that entire enterprise, thousands of different payer codes. And so one of the challenges to ACOs who want to report the Medicare CQMs is collecting all of that payer data and correctly organizing by Medicare and non-Medicare. So once you're doing that, you want to validate, do we have the right population? Is this the right size of Medicare population that we should expect to report on? And the CMS is providing that quarterly file now, new for the claims data for the ACO Medicare CQMs. And the nice thing about that file is it helps us validate the size of these populations. In a couple of instances, we've helped our clients understand that they were underreporting, sometimes significantly, the size of their Medicare population. So that helped them find some gaps in the reporting and the way they were collecting claims and submitting the claims data for us to calculate those denominators. So it's been really helpful as a reference tool. I know there's some mentions in the rules about using it as using the claims files for these Medicare CQMs as actually the denominator file. And we tend to prefer not to do that for a variety of reasons. The claims data allows us to further validate that we can also report the all-payer, all-patient version that's also available to ACOs. And so they've got two options, and if they want to look at both options, it's a great way to allow them to look at both of these options with the filtering. But there have been some challenges by collecting all of that payer data. The other issue that we would see with using the CMS file as a source of creating a denominator is that those files come very late. So the real challenge to using the claim files from CMS as a source for the denominator for the Medicare CQMs is the delay in getting those files. The final file isn't available until February, so that's very late to sort of look at your fourth quarter data. But even throughout the year, those files are not available until kind of the start of the next quarter. So using the claims files from CMS to construct a denominator for the Medicare CQMs is problematic in that way, but it's a great resource for helping us validate that we've got the right size of populations.
Well, thanks, Laura. That makes an awful lot of sense.
Another question for you is we're thinking through the Medicare CQMs. Some of the questions that come from our clients is about these Medicare CQMs. Can they be submitted like an eCQM through the EHR, or do they need to be reported through different methods?
Well, it's possible, Laura. Our client's EHR would have to be functioning as a qualified registry, not as a certified eCQM provider, in order to submit the Medicare eCQMs. And they would still have the challenge of identifying patients and deduplicating patients across all practices and all EHRs, not just their own. Now, EHRs do not generally play well together. ACOs generally have multiple EHRs in participating populations. It would actually be possible for more credible for your EHR to claim to be able to do Medicare CQMs for you if there's only one EHR and one instance of that EHR in your ACO. But they would face a significant problem generally to deduplicate and identify patients across all practices and identify those patients to the clinical data that populates the numerator.
And then what questions should we ask our practices or clients to be thinking about for their EHR vendors about how to support these Medicare CQMs? What can vendors do?
Well, a couple things. As you're choosing a vendor, as you're talking to your EHR about this, one, ask them if they're a qualified registry. If they're not, they really just don't understand the specs for the Medicare CQMs. Ask them, how will you identify and deduplicate the patients across our multiple practices? It has to be a credible technique. And how will you normalize the clinical numerator data to generate metrics across all EHRs? And how are you going to deal with missing data? If there's critical things that we have recorded, but we're not recorded in a way you could find it, how are you going to deal with that? And in fact, these are questions you should be asking even if you're expecting them to do an eCQM submission for you. Of course, they don't have to be a qualified registry to do eCQMs. You just have to be certified. But those are still the pertinent questions. Can you identify and duplicate patients? Can you normalize the clinical numerator data? And how will you deal with missing data?
Thanks. Those should be helpful questions for practices to be thinking about. This certainly is generating a lot of discussion out there within the community, the health IT community, about how to address these measures. So we talked a little bit earlier about this quarterly list that Medicare provides to help with the Medicare CQM reporting. So does this list just mean that it's really easy to report these Medicare CQMs using the list?
No, Laura, I think as you said, the last list is a bit late, and it's not a trivial problem that it's expected to be delivered in February with a submission deadline the end of March. It's a little late to comfortably use for your final full year submission. And you also are facing the same problem that you're facing with any source of denominator data. You have to confirm eligibility. From our early experience, we can't just take it for granted that Medicare's exactly right on the eligibility for each measure. We have to confirm that with service codes and the ICD codes checked from wherever we get it. And we still have to identify the patients to the practices where they were seen and to the clinical numerator data, which again is not a trivial matter. It's pretty much the same for Medicare's derived list and where we usually get it, which is from your claims generated in the practice. Using your claims gives us at least an extra month to 2 months to generate that final submission than waiting for Medicare's file to get in. And also, we're doing it through the whole year at whatever frequency you'd like to do it to check up on your performance as you progress.
And then for these Medicare CQMs, do we need to report on 100% of that denominator?
No. It's Medicare reporting is subject to what they call a data completeness requirement. Now, typically for most electronic submissions, you get all the data from all your patients and they're usually 100%. But when although electronic submissions in ACOs are a different beast than in single location practices with a combined EHR, there's some you'll have trouble getting data from, and Medicare's requirement is 75% of the eligible patients have to be included in the submission. So if you lose a couple practices because you just can't work them into the data, you can't normalize the data and bring it in. As long as you're above 75% of the data, it's okay.
And then on this next question, from the ACO's perspective, the Medicare CQMs are seen as a way to optimize your score, right? I have more manual chart abstraction, especially for Measure 134. I have a huge population. I can't get to the 24,000, but I can get to the 12,000. And I can improve my performance with manual chart review. And that's really the main attraction, is that manual chart review volumes being much more manageable for the ACOs.
You're right, Laura. That's an interesting observation. I think it may be somewhat of a toss-up what to expect because there's counteracting events going on here. If it would be entirely true that if your score was based on the absolute value of the performance score, you'd do better. Anything that involves a manual data abstraction tends to score better than the electronic, simply because if you miss data, it's going to reduce your score, not increase it. The nature of reporting is it takes an action, it takes a number to flesh out the high performance. If it's missing, it looks like you didn't do it, even if that number would be good if you found it. So for that matter, you might get you're expected to get a much better raw score from anything that involves manual abstraction, or even just from MIPS CQMs, which we can cast a much broader net to get your answers from the clinical data, whereas eCQMs are got a much narrower approach. You have to have a very specific documentation workflow to make it show up. So your raw numbers are going to be higher, but then you have to realize that they get scored not on the raw numbers as on a curve or as a percentile rank. So if all of your competitors are highly functioning, you're more likely going to be stacking lower in that list, in that high functioning group, than if eCQMs and MIPS CQMs, your competitors are all practices in the U.S. And I'm expecting that ACOs who are baking this shared savings, they're baking this financial gain into the process, and they're submitting their quality data in order to qualify to collect all of their shared savings. They have a bit more skin in the game. They've got a bit more impetus to perform highly. So the field is more competitive. I expect, therefore, the percentile rankings to put you at a lower level for any particular raw performance than it would from eCQMs to MIPS CQMs. Now, that's not going to be an issue in the first 2 years. Medicare is proposing in the new proposed rule for 2025 that they use raw scores and pre-publish it to tell you what your score is going to be at any performance rate in the first 2 years. It takes 2 years for any new measure or new measure type to generate the historical data from which they typically generate their annual benchmarks.
Interesting. Good food for thought. And certainly we'll be taking that back to our ACO clients to share those thoughts with them. So how can Mingle Health help those ACO clients with the Medicare CQMs in summary?
Medicare CQMs are the same process as our usual MIPS CQM process. The only difference is restricting our eligible patient list to the Medicare Part B recipients who have seen a primary care provider in your ACO in the performance year. In fact, if we get data to our preferred specs, we can toggle back and forth between Medicare CQMs and MIPS CQMs with just the flip of a filter. Laura, I think this has been a pretty good session for me. I don't think I have any other questions to ask of you. How about from you?
No questions from me. A lot of good information to share with our ACO clients, and very helpful. Thank you.
And thanks to our listeners for your questions and comments. We want to be helpful. We want this to be useful to you. Don't hesitate to correct or supplement our answers. Share your experience. Ask your questions. Ask for additional clarification. We can be smarter together.